CataractCoach.com. My best pearl for Flomax or IFIS cases. Floppy iris and moderate pupil size can be easily managed. So here's a case. Patient takes Flomax or tamsulosin and does suffer from floppy iris syndrome. This is the second eye. And we're starting off by making a presentation and putting in anesthetic. And look where I put it, a little bit under the iris. That's about 1% preservative-free lidocaine. You can also put in epinephrine, maybe a concentration about 1 to 10,000. And now look at the viscoelastic. That's your dispersive viscoelastic doing viscomydriasis. So using that viscoelastic to push that pupil margin, expand it just a little bit. Let's get our main incision done. Important to have a good incision so you don't get iris prolapse out the incision. So good tunnel length, taking our time, a little bit on the long side, which is what I want in an eye like this with floppy iris. Barely nicking those limbal vessels. Now here's critical. You got to make a big rhexis. Do not make a baby rhexis here. I want the rhexis to be at least as big as the pupil. That would be exactly 5 millimeters. And in fact, I'll make it ever so slightly larger than the pupil. So maybe about 5.25, maybe even 5.5 millimeters. And you can see that's going around very nicely. Look at the pivoting motion that we're doing to keep this AC formed and prevent loss of viscoelastic. Here comes the number one pearl. You want it? Here it is. Hydrodissect, slow and steady, keep going, till it prolapses partly out of the bag. And now here, tilt it up. Look, I dig the cannula into the nucleus and lift that nucleus up so that the pupil, the iris, is holding the nucleus for me. A little small aliquot of dispersive viscoelastic to protect that cornea in the center. And now, time for phaco. The cataract is actually holding the iris away. It's extending and distending even that dilation and holding the iris into the angle of the eye. So I can now work centrally here and chop and now emulsify the cataract very efficiently. And you can see the iris wants to move, but I'll just stay central. And the nucleus actually helped me hold the pupil open. And in fact, the other way as well, the iris help to hold the nucleus at the iris plane. A little bit more chopping here, and then emulsify that nucleus. And look at that. We're just about done. So you can see how incredibly efficient it is. And so here's the very last heminuclear piece. Again, chop it again. Small pieces, take these pieces down. Look at the placement of the chopper in the safety position. I don't want that bag to come up. Be very cautious here. And notice how we're also operating with the phaco probe in the center. I'll bring the piece here with vacuum, and I'll bring it centrally before emulsifying it. And now, just like that, 3 minutes into the case, nucleus is out. Just like that, super efficient. Now for the cortex removal, that should be pretty easy, but you have to make sure that we're not going to leave any cortex behind. So we don't have maximum dilation here, so we're going to have to use that probe to really get into the angle or the equator of the capsular bag, under the angle, and make sure that we have all the cortex aspirated and removed. Now, if we need to, we can use the chopper in the second hand to help lift up the iris and give us more visibility. And there you go, pretty well cleaned up. I'll kind of go around here, do a little polishing. There's a big PVD or posterior vitreous detachment you see there in the vitreous cavity. We're obviously not going to worry about that at this point. And that looks great, nice and clean. Now, when you put the lens in the eye, first thing is with the cohesive viscoelastic, get a good fill of the bag, deepen the bag itself. And now enlarge the pupil with more viscomydriasis. And now let's make sure the IOL goes in the bag. Do not let this single piece lens end up in the sulcus or even partly in the sulcus. Because as you know, you'll get like a UGH syndrome, uveitis, glaucoma, hyphema. That'll be a bad situation. So let's put this lens in the bag, nice and easy, deliver it in there, get those hapax open up, and we'll get this lens into the appropriate position here, rotating it around, making sure it's in the bag completely, and I'm very satisfied with that. Now take the IA probe in, I'm going to get the viscoelastic out from behind the IOL optic, and then of course we'll clean it out from the anterior chamber. So I've presented to you here an unedited case, start to finish, as I like to call it, my complete cataract case. And you can see that even in a case like this with floppy iris and a max pre-op dilation of maybe 4.5, at best 5 millimeters, you can still complete the entire case with zero issues in a very efficient manner, very safe, very controlled manner without having to resort to a pupil expansion ring or iris hooks. Now at the end here, we'll seal up the incision. You can see now the outline of the incision. I made it a little bit on the longer side just to make sure it's going to stay sealed and not allow iris prolapse during the case in case we ran into extreme floppiness. So washing out the little strands there of viscoelastic, get those out of the eye. And that lens you can see is a EDOF lens, so make sure that lens is beautifully centered up. So that's my number one pearl. That is, get a good rhexis and get that nucleus out of the bag.